Good evening, everyone. I warmly welcome you to our fourth webinar titled Understanding the Role of CRP in Patient Management and Antibiotic Use, brought to you by Wonderful in collaboration with Blue Health Ethiopia. I am Dr. Meti, your host for today's session, and I'm the product manager at Wonderful Ethiopia. It's truly an honor to be your host today. We're thrilled to have attendees joining us from various countries, whether it's morning in the USA for some of us, evening in the Philippines, or afternoon here in Ethiopia. Thank you for being with us at Wonderful. We're committed to supporting healthcare professionals with innovative diagnostics and educational opportunities. This webinar is part of that mission to equip clinicians with the tools and knowledge to make informed decisions and ultimately improve patient outcomes. Today's focus is on C-reactive protein testing, a valuable marker in diagnosing infections and guiding antibiotic use. With global concerns around antimicrobial resistance, this discussion is more timely and vital than ever. Before we start, let me briefly walk you through the agenda for this webinar. We're honored to be joined by two distinguished speakers, each bringing unique expertise from the fields of emergency medicine, infectious diseases, and also one full staff member who will share insights about our product. So that's all about our agenda. Before we begin, a quick reminder, please be sure to keep your microphones on mute while the speakers are presenting. If you have any question, feel free to send them to the chat box on the right side of the screen. We'll address them during the question and answer session. So now let's begin by introducing our keynote speaker. Our first speaker is Dr. Jane, a consultant internist and infectious disease specialist based in the Philippines. Dr. Jane holds a fellowship with both the Philippine College of Physicians and the Philippine Society for Microbiology and Infectious Diseases. She currently serves as at St. Luke's Medical Center, Manila Doctors Hospital, and Marikina Doctors Hospital. She will be speaking on the role of CRP in infection assessment and antibiotic use. Dr. Jane, are you ready to begin?
Hello, good evening. It's evening here in the Philippines. So let me just share my screen. All right. So I'll begin now. Tonight I'll be going to talk about the role of CRP in infection assessment and antibiotic use. So I have nothing to disclose. Everything that I will say and show during this presentation are mine and mine alone based on research combined with clinical experience. Here are the objectives of my presentation for tonight. So let me start with a term we've all heard inside the hospital, sepsis. A lot of patients hospitalized for an infection always ask their attending physicians about this. Do I have sepsis? Am I going to die of sepsis? Well, indeed, sepsis remains a major cause of morbidity and mortality around the world. So the following gives us an overview of the global burden of sepsis, and as we can see, the numbers are huge. And people at risk are those who are adults 65 years or older, people with weakened immune system, people with chronic medical conditions such as diabetes, lung disease, cancer, and kidney disease, people with recent severe illness or hospitalization, even those sepsis survivors, and of course, children younger than 1 year old. So, what is sepsis? It is the final common pathway to death for severe infectious diseases. The concept and understanding of sepsis has evolved over time as medical knowledge, pathophysical, etiological factors, and clinical progression have increased and improved. The most recent definition is from Sepsis 3, which defines sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection, where organ dysfunction is identified as an acute increase in the total SOFA score of 2 or more due to infection. So as we can see in this conceptual model, there is an interplay between many variables that can determine a patient's clinical course during and after sepsis. A lot of times, we encounter our patients here, where they are already with beginning sepsis, or even already hospitalized due to sepsis. Our goal as clinicians then would be able to diagnose timely so that management can be instituted promptly as well as to monitor for any complications or progression to be able to reach recovery. Hence, early recognition is necessary. We can suspect sepsis if we see these signs and symptoms. Oftentimes, there are also some scoring systems that are being used inside and outside the hospital. However, symptoms of sepsis are non-specific, while signs, as clues to identify the source of infection, are not always apparent. So this is where biomarkers can help. If you recall earlier, we said that there is an interplay between many variables that can determine a patient's clinical course during and after sepsis. A biomarker is a measurable indicator of biological status in normal and pathogenic processes. They are categorized based on their diagnostic or prognostic rules, which may help identify suitable patients for therapeutic intervention and titrating the degree and or duration of intervention. So in a way, it is a surrogate marker of the body's response to an event. Biomarkers should be accurate and reproducible. Faced with the suspicion of sepsis, the clinician has several questions to address. Clinicians frequently try to answer these questions with the aid of biomarkers. What is the likelihood of infection? What is the severity of illness and the risk to develop septic shock? What is or are the most likely pathogens? What is the most appropriate antimicrobial treatment? Is the patient improving or not? And if not, why? When can my antimicrobials be stopped? It is important to acknowledge that biomarker performance in sepsis management is suboptimal. Generally, there are seven types of biomarkers, namely susceptibility or risk, diagnostic, monitoring, prognostic, predictive, pharmacodynamic or response biomarkers, and safety biomarkers. One useful diagnostic and host response biomarker of sepsis is C-reactive protein, or commonly known as CRP, which is the main topic of our lecture. As a history, it is first isolated in 1930 from the plasma of patients with pneumococcal pneumonia. CRP was so named because it binds to the C polysaccharide of the pneumococcus. It was found that CRP is present in the serum of patients with disorders other than pneumococcal infection, but that it rises strikingly whenever there is tissue necrosis. It was later found that the protein appeared in plasma during many infectious or inflammatory conditions, and CRP was the original acute phase reactant. CRP has now been characterized as a member of the pentraxine family of proteins exclusively synthesized in the liver when exposed to inflammatory cytokines like interleukin 6 and interleukin 1 beta. Many other substances react with CRP such as DNA, nucleotides, various lipids, and other polysaccharides. Thus, it appears to serve as a general scavenger molecule. It opsonizes particles and activates complement via the classical pathway, but its actual biological function is unknown. The normal serum concentrations are about 100 nanogram per ml at birth, 170 nanogram per ml in children, and 470 to 1,340 nanograms per ml in adults. It has a median of 1,000 nanogram per ml or 1 milligram per liter. So just take note of the units that are being used in your laboratories. Despite these low concentrations, CRP has major significance as a highly sensitive acute phase reactant because it is fastest to rise and it returns to normal quickly following successful therapies. In individuals with acute illness, cytokines stimulate hepatic production of CRP, and plasma levels may increase up to 300 milligrams per liter, or it is actually equivalent to around 300,000 nanograms per ml or more within 4 to 6 hours, doubles every 8 hours, and peaks within 36 to 50 hours. It has a half-life of 19 hours and it may correlate with disease severity. So as we can see in this table, it compares C-reactive protein and another most commonly used host response biomarker, which is procalcitonin. In contrast to procalcitonin, CRP is not affected by steroids, neutropenia, renal failure, or renal replacement therapy. However, there may still be some confounders, such as since it is being synthesized in the liver, there may be false negative results in chronic liver failure, where CRP is seen to decrease around 70% of the normal. Quantitative determinations are very helpful in recognizing a variety of disorders. As serum CRP rapidly rises and falls with onset and resolution of um, inflammation, patients having an acute and severe inflammatory response are easily diagnosed. This is why CRP is often used by rheumatologists to monitor the progression or remission of autoimmune diseases. A high sensitivity assay for CRP can add to the predictive value of serum lipids for identifying individuals at risk for cardiovascular events, presumably owing to the role that inflammation plays in atherogenesis, aiding to the diagnosis of stroke or myocardial infarction. CRP is frequently applied to the detection and preliminary classification of occult infections because bacterial infections can stimulate much higher levels of CRP than viral ones. But note that these must be correlated clinically. Also, although it is usually not increased in viral infections, a known exception is what we have seen in COVID infections, where a hyperinflammatory state is present, thereby causing an increased CRP. CRP measurement is cheap and rapidly available, but increases of CRP levels may be unspecific, since they can also be observed after surgery or trauma. But in general, it can be a guide to therapeutic efficacy because, as I have said, it appears to be an earlier and more sensitive indicator of acute inflammation and infection and can be quickly measured. So let us correlate with some tests. So there is first case of patient ASD, a 35-year-old female, known breast cancer patient, stage 4, with metastasis in presenting as pleural effusion, who underwent bilateral chest pigtail insertion last 2024. She had her last chemo 3 weeks prior and is now due for the next chemotherapy session. 1 week prior, she had started to complain pain whenever left pleural fluid is drained, but the output remained to be clear and serous. She denied any presence of fever, chills, cough, or difficulty of breathing. There are also no signs of inflammation or infection around or surrounding the chest pigtail site. She was then advised admission for evaluation and also in preparation for her chemotherapy. However, when she was admitted, there was noted left chest pigtail leakage, hence she was scheduled for replacement of the left chest pigtail. She had normal vital signs, was febrile, and had decreased breath sounds bisally. Laboratory results showed that she had unremarkable CBC, actually normal, with procalcitonin, which is negative or less than 0.5, but an elevated CRP of 24. Urinalysis was pretty much unremarkable, and chest X-ray just showed bilateral non-loculated pleural effusion, which cannot rule out an underlying pneumonia. A blood culture in preparation for chemo IDS clearance was done, but there was no growth of any microorganism. So just basing on the history, physical exam, and preliminary lab results, we only have an increased CRP. The patient pretty much has no other signs of infection. But as we can see in the course of the patient, she underwent replacement of left chest pigtail, and cultures were sent for the fluid. And behold, a bacteria known as Enterococcus gallinarum, which is vancomycin resistant, grew from the pleural fluid culture. And so the patient was assessed to have empyema thoracis and is treated with ampicillin for 3 weeks. And as a course of her hospital stay, she was um, subsequently discharged and has been continuing her chemotherapy because she has now recovered. So, in this case, this shows the utility of CRP as a diagnostic marker. A study done by Simon et al., which enrolled 12 prospective studies that included hospitalized patients from all age groups evaluated for bacterial infection, compared serum procalcitonin and CRP as markers of bacterial infection versus non-infective causes of inflammation and viral infections. It was noted that procalcitonin markers have significantly higher accuracy than do CRP markers for discriminating bacterial infections from non-infective causes of inflammation. The pooled sensitivity and specificity of CRP for diagnosing bacterial infections were 75% and 67% respectively, with positive and negative LR, or likelihood ratio, being 2.43 and 0.42 respectively. When evaluating bacterial versus viral infection, procalcitonin markers were again significantly better. The pooled sensitivity and specificity of CRP for diagnosing bacterial infections were 86% and 70% respectively, with positive and negative likelihood ratio being 3.75 and 0.20 respectively. Though procalcitonin performed better for both aspects, considering that CRP is cheaper and more available, its determination could still decently guide treatment owing to its high sensitivity, although quite poor specificity, and it could still decently guide treatment and reduce unnecessary antibiotic use. Another study done by Pradhan and Nepal enrolled 64 ICU admitted patients with MR or SARS in a 1 year period, evaluated the diagnostic accuracy of CRP obtained within 48 hours of the diagnosis. They used a cutoff of 50 milligrams per liter for the CRP compared to the gold standard. So their gold standard is if there is a positive culture, an isolation organism should be noted, while if there is a negative culture, a CDC criteria for sepsis was used. So their outcomes was diagnostic accuracy. Unfortunately, there was no mention of study design used. Nevertheless, their findings are still worthy to see as it provides an insight on the usefulness of CRP in identifying patients with sepsis. So the authors noted that CRP had a sensitivity of 84.3%, specificity of 46.15%, positive predictive value of 84%, and negative predictive value of 42.8%. So it is quite similar with the first study that I've showed that it has a quite high sensitivity, but a bit poor specificity. So the area under the receiver operating characteristic curve was 0.683, and the cutoff value that they've noted with the best diagnostic accuracy was found to be 61 milligrams per liter for this point of care testing. So it gave quite the same numbers of high sensitivity and low specificity. So let me just brief this through. When we say that there is a high sensitivity of the test, it is a high sensitivity test would give us a high confidence that we can rule out the presence of the disease. However, with the low specificity, we can, if it is positive, we may or may not have the confidence to say that the patient has the disease. This means that we still need to correlate clinically for the patient. So the diagnostic accuracy was also tested when CRP was combined with other parameters of sepsis, as shown in Figure 1. And see that when combining with CRP, the sensitivity and specificity could not increase above that provided by CRP alone. So these results show that CRP, when used with its traditional cutoff, as suggested by International Sepsis Definition Conference in 2001, which is two standard deviations. It could be too non-specific and will probably include many non-infectious inflammatory conditions as well. Diagnostic accuracy of CRP, even when using such high cutoff values, has been variable and debatable, and differences in observation may be attributed to the accuracy of diagnostic kits, causes of infections, and patient-related factors. Nevertheless, CRP could be very useful in resource-limited places where newer biomarkers, such as the procalcitonin that I've mentioned, or interleukins, are not available, and when there is no guidance of an intensivist or a trained sepsis expert. So let's go to the next case, which is our patient MVR, a 59-year-old female, known case of breast cancer, stage 3A, underwent MRM bilaterally, right and left, with right being done first, and is currently on remission. 1 week prior, she presented with left anterior chest pain aggravated by deep inspiration. Upon ER consult, she was diagnosed as having community-acquired pneumonia low risk and was given cefuroxime. 3 days after, to consultation, she complained of a purulent discharge from left anterior chest over the previous site of her MRM. But she denied presence of fever, chills, limitation in movement, and there is no history of trauma. On physical examination, she remained to have normal VS and was a febrile but with erythematous anterior chest with purulent discharge from post-MRM scar and was non-tender. Preliminary laboratories showed that she had leukocytosis with leftward shift, an elevated or CRP, chest X-ray showing no pneumonia, and with abscess on the left anterior chest concurrent with an osteomyelitis. So the patient eventually was diagnosed with left anterior chest wall abscess with osteomyelitis and underwent wound exploration and debridement. Abscess and bone fragment culture both grew Staphylococcus aureus methicillin resistant or MRSA, and she was then treated with linezolid for 2 weeks from source control. On day 5 of antibiotic therapy, she was noted to have decreased ESR and CRP. So, this case now presents a decrease in the inflammatory marker, mainly CRP and ESR, after instituting antibiotic therapy. So, this now reflects the utility of CRP as a host response biomarker. A prospective observational cohort study done by Coelho et al., which enrolled 191 patients with severe community-acquired pneumonia that required ICU admission, excluding those with severe immunosuppression and TB, evaluated the difference of CRP ratio and its patterns of response between survivors and non-survivors. So at day 1, CRP concentration was not significantly different, but the course of CRP ratio during the first week of antibiotic therapy showed a steady and significant decrease in survivors. By day 5, this divergent evolution of CRP ratio was markedly different, with the CRP ratio becoming as low as 0.46 in survivors, but remained elevated in non-survivors at 0.79. The ability of CRP ratio by day 5 to predict outcome assessed by the area under the receiver operating curve was 0.73. So by day 5, concentration above 0.5 of the initial level was a marker of poor outcome with sensitivity, specificity, likelihood ratio shown in the slide. So only 3 variables were noted to be independently associated with ICU mortality, namely day 1 SOFA score, day 5 CRP ratio of greater than 0.5, and mechanical ventilation. So patients with severe CAP were retrospectively divided according to 3 patterns, and as they have shown in this time-dependent analysis in figure 1, CRP ratio variations of 3 different patterns was statistically different. So by day 5, CRP ratios were 0.23 for rapid responders, 0.74 for slow responders, and 1.47 in patients exhibiting non-response. So this means that the non-responders remain to have an elevated CRP. So the clinical course during antibiotic therapy was also monitored with SOFA score, and likewise, the non-responders showed a poorer outcome. So these findings show that with resolution of infection, the concentration of CRP decreases at a rate that is dependent on its half-life. Survivors showed a continuous and significant decrease of CRP ratio, while non-survivors, CRP ratio remained elevated as higher than zero point 0.5 and was associated with fivefold increase in the risk of death in ICU. So patients with non-response CRP presented a significantly higher ICU mortality than fast or slow response patterns. So these data suggest that persistently elevated CRP values are indicative of poor response to antibiotic therapy. So this could be a result of various factors, such as inadequate initial antibiotic therapy, presence of other infectious complications, development of new infection in another location. Thus, serial measurements of CRP are useful in the monitoring of clinical course as well as assessment of patients' outcome in different severe infections. It allows identifications of various patterns of response to antibiotic therapy. So, in fact, the identification of CRP ratio patterns of response in combination with clinical evaluation is a useful tool with good potential to reduce the length of antibiotic therapy, as well as to reduce the risks of emergence of resistant strains and cost of medication, a hypothesis to be tested in future trials of CRP-guided therapy. So a prospective observational cohort study by FOA et al. Enrolled 7 adult VAC patients with microbiological confirmation similarly evaluated the difference of CRP ratio and its patterns of response between survivors and non-survivors. So in general, it is similar to the first study that I've shown, where fast responders and slow responders have lower mortality rate and had decrease or rapid decline in CRP, whereas non-responders or those with biphasic responders had higher mortality rate and their CRP ratio level remained high. Now, on figure 2, it showed steady and significant decreases as well of CRP ratio in survivors, whereas in non-survivors, these parameters remained almost unchanged. And at day 4, the CRP ratio of survivors was 0.62 relative to the initial value. So at day 4, the CRP ratios in survivors compared to non-survivors was lower than the baseline, and non-survivors had remained almost unchanged. A CRP um, a CRP ratio is thus noted to be a marker of poorer outcome if it remains high in patients, especially for non-responders and biphasic responders. So figure 3 showed at the end of antibiotic therapy, the CRP concentration of survivors was 3.5, whereas in non-survivors, it was elevated at 26.2. So only three variables are independently associated with mortality, such as day 4 CRP ratio, age, and day 0 SOFA. So overall, findings of this study showed that again, serial CRP measurements could be used as a marker of resolution of infection and might be of some help in the clinical decision-making process for the reassessment of patients that fail to improve. The individual pattern of CRP ratio response to antibiotics appeared to be a reflection of clinical course independent of other possible confounders. So in patients with BAP, with rapid CRP protein ratio decline, a shorter duration of antibiotic therapy could be equally effective, reducing the risks of emergence of resistant strains and costs. Conversely, in patients showing patterns of non-response and biphasic response, an aggressive diagnostic and therapeutic approach should be attempted in order to prevent further clinical deterioration. Now that we've discussed how CRP can be used for diagnostic and post-response evaluations of patients assessed to have sepsis, we go back to this slide I showed earlier. As suggested by the various studies we've reviewed, high CRP suggests high likelihood of infection, more severe illness with higher and sustained CRP levels, which is usually bacterial. Now, the fourth questions cannot be addressed by CRP or any biomarker alone, as only culture results can definitively give this information. However, as we have seen earlier, serial CRP measurement can give us an idea if antimicrobial treatment is working or not. This, in a way, also answers the fifth question. These two questions emphasizes that CRP levels should not be used as a sole criteria in initiating and assessing appropriateness of antimicrobial therapy. As noted in study reviews we've seen, there are other predictors of mortality such as SOPA score and clinical course of the patients. The sixth question is likewise a combination of clinical evaluation and diagnostic evaluation with serial measurement of CRP giving us an idea. There is no single guideline that establishes the optimal cutoff for CRP, especially in stopping antibiotic therapy. So there are some suggestions, such as stopping when CRP has decreased more than 50% from baseline or until CRP is less than 25 milligrams per liter. But, as I have emphasized, this should never be used as the sole criteria in making clinical decisions. It is important to do thorough and daily clinical assessment as biomarkers are just suggestive and not the gold standard diagnostic marker. It should be noted that immunocompromised patients and those requiring long-term antibiotic therapy may have unpredictable course, and thus as clinicians, we should not be content with just biomarkers. Such algorithm-based antibiotic therapy promotes diagnostic stewardship, which is auxiliary to antimicrobial stewardship. So if we have the three right Ds in antimicrobial stewardship, namely the right drug given at the right dose and the right duration, diagnostic stewardship is comprised of ordering the right tests for the right patient at the right time. Proper interpretation of test results in conjunction with careful consideration of clinical signs and symptoms is essential for diagnostic stewardship. So for our learning points, sepsis is a complex continuum of disturbed systems and remains a major cause of morbidity and mortality. Underdiagnosis and inadequate antimicrobial therapy could be fatal. Biomarkers are surrogate markers that can potentially aid in the diagnosis of bacterial infection and therapeutic efficacy evaluation. C-reactive protein is a diagnostic and host response biomarker that can be used as an adjuvant but not as replacement to thorough clinical assessment. It boasts a high degree of sensitivity yet indicates restricted specificity. Diagnostic accuracy can vary significantly depending on clinical setting and patient population. Serial measurement rather than single value is more important when evaluating for therapeutic efficacy, especially in cases of bacterial infections. There are limitations to CRP use, including patient factors such as comorbidities and unpredictable course of infection. Diagnostic stewardship by early intervention and shortening antibiotic duration can be possible with the aid of CRP-based algorithms, comprising of doing the right test for the right patient at the right time. So the following are my references, and thank you for listening.
Thank you, Dr. Jean, for sharing those valuable clinical insights. We will now take a few moments for question and answer from the audience. Please drop your questions in the chat box. We'll take one or two questions from there. So I'm seeing one question here. I think he wants to maybe know the difference between CRP and ASR and clinical value of both, comparing both ASR and
CRP. Yes.
CRP.
So ESR, I've mentioned earlier in my case, was also requested, and it also showed elevation in inflammation. So like CRP, it is also an inflammatory biomarker, but since it is so-called as erythrocyte sedimentation rate, it is paired with erythrocytes. So it is not just affected by any acute inflammation, but some some forms of chronic inflammation can also affect the values. In contrast, CRP, as I have said or mentioned earlier, rises more acutely with any changes in host response and host inflammation, which means that it is more present in acute inflammation. So, usually in some suspicions of infection, we request both, but more commonly, if we suspect of an acute um, process ongoing, CRP has more value.
Okay. There is any more question? Okay, there is one. Is there cut point of CRP level to differentiate bacterial infection from inflammatory conditions?
I have mentioned earlier in my presentation that there is no optimal cutoff, but as we have seen in some reviews, they did some cutoff in their studies, and the one study showed that the optimal cutoff is around 50 to 60 milligrams per liter. But ultimately, if we are going to diagnose, we're going to see an acute rise of CRP, and it can give an idea, but since it is also affected by some other forms of inflammation, also with other insults such as surgery and trauma, we should also pair it with clinical correlation. And usually, more utility is seen with serial measurement. So we compare it from the baseline, which means a single value is not that useful as compared to serial measurement.
Okay, let's take one more question. So in a clinic, we have applied serial CRP measurements for patients who were clinically diagnosed for bacterial pneumonia, and results showed CRP dropped with clinical improvement.
Yes, I think that's so was it was also the same with the case that I have showed. So it's like the CRP acting as a host response biomarker, showing that serial measurement, it can show that there is response to antibiotic therapy. So therefore, you can make some judgments on whether you will continue or stop antibiotics or even change antibiotic if there is non-response.
Okay, that will be all for the questions. Thank you so much, Dr. Jane, for the answers. So let's move on to our next speaker.
Okay.
We are
Thank you
pleased to
for
welcome
those
Dr.
questions and
Temesgen.
for listening.
Okay. Okay, Dr. Temesgen is an associate professor of emergency medicine and a consultant in emergency and critical care medicine at the Gurambessa Hospital Specialized Hospital. He's currently a visiting scholar at Stanford University and a recipient of Stanford African Scholars in Global Health Award with a focus on antimicrobial stewardship in emergency department. His extensive training includes Harvard Medical School, Queen's University in Canada, in the Ultrasound Leadership Academy. He has been a global fellow at Brown University Center for Human Rights and Humanitarian Studies since 2017. He also served as the chair of the Department of Emergency Medicine at Addis Ababa University and currently practices at Gurambessa Specialized Hospital, Ethiopia's largest surgery care hospital. Dr. Temesgen is an experienced academician, a dedicated leader, and a passionate advocate for lifelong learning and healthcare improvement. Please join me in welcoming Dr. Temesgen Beyene, who will present on clinical application of CRP, testing in emergency care, and antibiotic decision making.
Okay, thank you, Dr. Messi. Good evening, everyone, and good morning from where I am based currently. It's in the West Coast. Can you hear me? Sorry. Can you hear me?
Yes, we can hear you, doctor.
Okay, perfect. Okay, I will take you through the clinical application of CRP as one of the markers where a lot is ongoing as far as its utilization is concerned. So I don't have any disclosures, and I will proceed with the outline of my talk. I will start with a brief introduction, as that is also covered by Dr. Jane, some of the different clinical application aspects, and finally the summary points about this. So, as we all know, and as this was discussed earlier, CRP is said to be an inflammatory protein, which is mainly produced by the hepatocytes under the stimulation from interleukin 6 and TNF, and its utilization is basically used in this pathophysiology framework. So it can help us in terms of clinical practice, either to identify, to monitor, or even to de-escalate our antibiotics utilization. Not only these inflammatory versus infectious issues, it's also a marker which is used in risk stratification for coronary heart disease and so on. This was also advocated by American Heart Association since the year 2003, as well as from the guidelines in 2013. You can see from this picture that its production is stimulated by interleukin and depends on the clinical presentation of the patient as well. If the patient is not having all the toxicity features as far as sepsis is concerned, at times it may not be the case to case a raise in CRP. But at the same time, CRP raise can also be incriminated with any of the inflammatory processes. That's where our clinical decision by using the tool itself as a point of care testing tool, as an adjunct, is quite important. One of the issues these days is the cutoff, as well as different laboratories taking different measurement and different cutoff values. So that actually created lack of universal application in terms of decision making for patient presentations and so on. So it's a classic acute phase protein from its inflammatory protein point of view. It can help us in terms of looking into the tissue damage. It can raise as early as within few hours time. It peaks so quickly. Actually, within the first 24 to 48 hours, you can see a significantly peaked CRP level. And subsequently, it may raise to hundreds and at times to thousands of higher than the normal range. In that scenario, the degree of the infectious presentation may also be correlated with that. So with effective treatment, at the same time, within 1 week, you can see a significant drop to normal levels. In some aspect, it reminds us the rise and fall of high sensitivity troponin when we order it in myocardial infarction and so on. So here, you can see the rise that peaks in that earlier hours and then subsequent drops. But the drop is associated with effective form of antibiotics therapy and so on. But at times, as I said, the specificity comes into question. So even with no infectious process, the raises and the fall can still mimic that of infectious presentations and so on. So there is this issue of measuring whole range CRP versus its high sensitivity form. The differences are during the high sensitivity CRP measurement, the machines are calibrated in a way to measure the fragments of that, which are quite sensitive and effective in terms of picking the abnormality, especially for those cardiovascular risk stratification strategies and so on. People use the high sensitivity CRP. What is measured for the infectious or for the inflammatory processes is either the whole range CRP or just CRP. So the CRP total is measured by taking the consideration of all of these. So from that point of view, still the detection can be somehow double form of detection. Probably from the technical aspects later on, we can hear these details during the laboratory measurement and so on. So the issue is the high sensitivity as well as the normal CRP They both belong to the same protein, and testing method is somehow different. So the high sensitivity, as the name indicates, just like for the high sensitivity cardiac troponin, it's, I mean, picking the right thing at the right time. So for the whole range CRP, there are level ranges where we can pick some of the infectious presentations and so on. And as I say, the cardiac risk factor identification and the strategies to prognosticate the patient presentations and so on. There are high sensitivity CRP ranges in the like 0.5 to 5 milligram per DL. And the CRP for the diagnosis and picking infection, be it in the adults or the childs, especially with the bacterial pathologies, is ranging from 5 to 200. But for treatment purpose, people take different literature support cutoff values beyond 100 patients. If the CRP is more than 100 with additional features of sepsis or infection, then it's better to proceed with antibiotics choice and so on. Again, the whole range CRP, there is no such significant variation in terms of the range where we take, but it starts as low as 0.5 milligram per DL for the normal category. So it helps us in terms of enhancing our ability to detect any infectious presentations and so on. But the sensitivity is quite good. The problem is when it comes to its specificity aspect. So to go for its clinical applications, focusing in the emergency department, the primary care settings as far as CRP is concerned, these are three major areas. It can be an infection indicator, in addition with our clinical judgment, with the clinical data. It can help in terms of decision making and also treatment monitoring at the same time. For example, to give antibiotics or not to give antibiotics for a lower respiratory tract infection, or to de-escalate and so on. And it's an important tool to fight for antimicrobial resistance. And with that, we can even observe our antibiotics efficacy and so on. So there was a summary that's put into CRP as a tool for diagnosis support, prognostic guidance, and antibiotics treatment follow-up, as well as a screening tool. So this is how non-specific CRP is. As you can see, for every sort of inflammation, multiple systemic diseases can end up causing the CRP. But the degree to which CRP raise can be used as a tool to start, to initiate, or to escalate antibiotics is, different in terms of different infectious presentations from the systemic ones, as you can see from here. So far, there were lots of studies done as far as respiratory system, especially for community-acquired pneumonia, for any lower respiratory tract infections, where CRP use is highly advocated nowadays. Otherwise, all these inflammatory processes, system-based, can cause raise in CRP. There may be future studies which can come up for each and syndromic presentations of infectious etiologies, so that we can decide when to use, what cutoffs to use, and so on. So here is one of the studies that was done by Gong and others, and that really showed how CRP is an effective indicator for picking bacterial infections. So they tried to look into a group of patients with bacterial pneumonia, mycoplasma pneumonia, and there were significant raises on the second day of admission. So some of the raises may not be, as such alarming as like hundreds or thousands of raise, but you can see the drops right after initiation of antibiotics and during the time of discharge. So this is in both groups. You can see a drop. And in fact, the decision to put these patients on antibiotics was not only based on the CRP identification, but CRP was an additional tool to that of the clinical decision for the treatment of the patients. The other is clinical decision making as well as monitoring patients. So from this point of view, people took CRP as an agent to decide outpatient versus inpatient care. So it has a role in terms of disposition decision. This is very important in the emergency rooms, emergency center, or emergency departments, where patients can have prolonged lengths of stay, just, taking the antibiotics in the emergency department or waiting for their admission, waiting for their laboratory results, and so on. But if we get this point of care CRP test, it's quite important to make this decision right away. So from that point of view, this was one of the studies which assessed how CRP is effectively used in terms of de-escalating treatment decision and how it helps in terms of strengthening our perceived clinical, physician decisions for out of hours outpatient emergency medical services. It was, I think, done in Europe, and they assess patients where point of care, CRP tests were used to reduce hospital admissions, and it really helped them to revise their antibiotics prescriptions to put, if someone actually needs the antibiotics or not, decision-wise. And it helped to increase confidence, and it also reduced uncertainty of putting the patient on antibiotics or not. And it helped to have better communication between patients, physicians, and so on. All in all, it helped the team for evidence-based practice where patients have a say, your experience matters, and what is on the ground as far as latest findings are concerned. So this is the graph from that same study. You can see the decision changes when CRP point of care test was used and how the antimicrobial therapy, other treatments, and so on changed quite frequently with the use of the CRP itself. So with that, that helped the team to effectively decide patients without a significant stay in that scenario without, having timely decision for admission or for discharge. So the other, benefit is for monitoring purpose. That can be for someone where surgery was done and subsequently continuous quantitative monitoring of CRP can be done to control if to put the patient on antibiotics or not, or if antibiotics is already there, when to discontinue, and so on. So for that, the team utilized, CRP during the post-operative abnormal responses, and they took the CRP test as an indicator of infectious complications. So that is in oncologic surgery and with primary reconstruction procedures. So it's for post-operative infections, and as you can see, patients were put on antibiotics depending on the judgment, not only with the CRP again, together with the clinical data and subsequent drops within days from the CRP. That was actually within like 1 week time, the CRPs came back to the normal range. So let me bring you this case. This was, a 65-year-old man near to geriatric age, presented to the emergency department of one of the tertiary care hospitals with an acute abdominal pain with back radiation and hypotension. Patient was hemodynamically unstable, just to make it brief, and with recent admission to the orthopedics ward for 2 days with a lumbar pain, discopathy of the lumbar vertebrae, and suspicion of aneurysm of the abdominal aorta raised from at presentation, and CT was done. So no acute pathology was seen except the dilatation of the stomach and small intestine. Lab results revealed leukocytes, no significant raise. You can see the CRP in like hundreds of times elevated, and you can see raised creatinine as well as the lactate level is also raised. So from this definition, the team right away decided, okay, this can be possible in septic shock, hemodynamic instability. Patient got admitted to the ICU, workups done, chest X-ray with no any finding, and the clinical presentation as well as the laboratory findings, patient was put on antibiotics, tobramycin, cefotaxime, and subsequently management continued, admitted to the ICU. Surprisingly, blood culture revealed Staph aureus. So this was a septic shock with unidentified focus from that presentation. And you can see right after treatment, almost 4 days, this is just the CRP as well as the lactate curve. Within that 1 week time with the treatment, there is a significant drop in terms of both the lactate and the CRP. So the raises were quite sky high during the earlier hours and then subsequent drops. And as this patient was stayed in the ICU for 1 month and discharged, that unfortunately readmitted with additional bouts of sepsis, and the patient died. So this was a series of 3 cases. I didn't brought the remaining cases just for the sake of time, but the whole point is, even in patients with no such fever or no leukocytosis and things like that, there is a significant rise in CRP, in addition to the clinical data that helped for the treating team to decide to put the patients on antibiotics. So the other option is as a tool to fight antimicrobial resistance. This is one of the areas where CRP use is highly, advocated and recommended these days. Well, there was this large data of patients, near to 10,000. It was actually 9,444 patients, where European expert panel reviewed the antibiotics overuse in European primary care. So as we know from literatures these days, there is this like over 50% of inappropriate antibiotics utilization, especially in the primary care settings, even in the emergency departments and so on, worldwide. So with that, antimicrobial resistance is a global health threat. It's a threat for everyone. So, and to make things worse, most of these prescriptions can occur in the primary care settings. When patients go to the tertiary care centers, they are already getting antibiotics, and there is that sense of, a threshold difference to stop antibiotics while the patient is taking that for days and so on, and then things like that. So with lower respiratory tract infections were the most common indications in this expert panel review. So they came up with an extensive report about CRP as a point of care testing for evaluation of lower respiratory tract infections, and also its utilization to limit prescriptions. One thing, how common is to use antibiotics in this category of patients, and then how effective it is to use CRP, and what are the challenges not to use CRP. Those were the review aims. So they stated CRP as a point of care testing is potentially useful tool that limit antibiotics prescriptions in scenarios like lower respiratory tract infection in a community setting, so that will help to fight for the antimicrobial resistance. And in fact, CRP use as a point of care testing with other strategies like improving the clinical skills of communication and use of molecular forms of POC testing that will enhance, in terms of fighting the antimicrobial resistance. So financial as well as logistical issues were potential barriers, but overcoming those and making, the CRP point of care test as a low cost option will help to overcome that challenge. And limiting antibiotics prescriptions, which was tried in different countries, may not be the case. It may not work, because even if limiting was there in the hospitals, from the healthcare professionals' point of view, there may still be a possibility that patients can gain access to antibiotics, even without any prescription. That's what's ongoing worldwide nowadays, especially for simple infections like respiratory tract infections and urinary tract infections. These syndromes, people can take antibiotics even without prescription. So CRP point of care inclusion as a standardized procedure with effective communication and awareness creation, also incorporating it into the local guidelines, as well as better patient education, can represent such an important cornerstone or a tool to fight for antimicrobial resistance. And their recommendation, at least for the European setting, was just to have better reimbursement structure so that patients will be aware, the primary care settings will be aware, and overuse of antibiotics prescriptions will be decreased with that. So this was a step-down approach that they brought from their summary. antibiotics prescriptions in general in the primary care settings in Europe were high. So that was the consensus from the team. And lower respiratory tract infections were taken for a special consideration because that's where this overuse is quite rampant. And alongside other techniques, they try to incorporate the POC, the CRP point of care testing as a key tool to fight this inappropriate utilization. They try to enhance the communication skills, diagnostics testing, and delaying prescribing or de-prescribing just by looking into the test results from the CRP and considerations for the current reimbursement structures and all those kinds of things. So with all this, they came up with this expert recommendation where local guideline incorporations, as well as making lower cost availability of CRP as a point of care testing for the team, so that will help to reduce this inappropriate antibiotics utilization. I think this is one of the model which can be, followed in other settings as well. As far as the availability of the testing is there, our clinical decisions are there. It's all about reducing irrational or inappropriate antibiotics use. So the third application, the final application that I'm covering here, is to look into antibiotics efficacy. So it can help in terms of observing therapeutic effects of antibiotics. And for this role, CRP is a better choice when it's compared with the other parameters like white cell count, ESR, or other biomarkers. At least this is well studied from this point of view. So we can see the mean value and the drops by comparing the three, the CRP, white cell count, and ESR. As you can see, there is this steady drop from the CRP. You can see the drop from ESR as well. And also there is a drop from white cell count. But the issue is with the ESR, there is this problem of even chronic conditions may cause raise in ESR and so on. So specificity is a problem, as it's also a problem in CRP. But at least for the acute presentations from emergency centers or primary care setting presentations point of view, at least the CRP use is well studied for looking into the antibiotics efficacy and so on. So when the antibiotics treatment is actually effective, the CRP decline is steady and it also declines quite fast. So at times in our practice, we can see a white cell count that is 20,000 or 30,000 range, and you may repeat that in few days, and the drop may not be as such significant for different reasons. That maybe we have patients having severe pain, lots of issues. So in that scenario, you can look into the serial CRP testing, and if there is a serial drop from that point of view, you can either stay with the same antibiotics to finish the course, or you can de-escalate. But if you keep on focusing only on the white cell count, there is this tendency to revise antibiotics, knowing that the culture turnaround time may take quite longer hours and so on. So in review, the review of the CRP test application, as I said, it can be used in the primary care settings, in the emergency departments to initiate antibiotics or not to initiate, or for decision making. And this can continue up to the ward and then to surgery patients for post-operative monitoring and so on. So all in all, CRP can be used as an infection indicator. Make sure that our clinical data is still there just by using the CRP as an adjunct. It can help us in monitoring after surgery if the patients are really having any post-operative state of infection or not. We can look into antimicrobial efficacy, what we are giving for the patient is working or not, and if the patient is responding or not, and so on. So you can use in that category as well. So its typical test application scenario can be in any of the GP clinic, in the general practice settings, or in the primary care settings, in clinical departments, in different clinical outpatient departments, in the emergency room, and so on. So this is quite, significantly studied and results seen in the South Asian context, in European context, and worldwide as well. There are studies, few studies in the low middle income countries tracing similar parameters, both in the adult and in the pediatric age group of patients. So from the emergency room, emergency department point of view, use of infection biomarkers in general in the emergency department is advocated, almost for decades, but it has given much attention just recently. So procalcitonin, CRP, and the other proadrenomedulin and pepsin, these are all biomarkers which can be used in the emergency department. But the issue is they all have variable sensitivity and different cutoffs. This created a problem to reach into a consensus, at least from the CRP consideration. The papers that are coming out these days, CRP can be used at least for the syndromes that arise in the respiratory system, particularly for community-acquired pneumonia, to reduce unnecessary antibiotics prescriptions. So all in all, CRP in patients with lower as well as upper respiratory tract infections and COPD, the acute exacerbations of chronic obstructive pulmonary disease, it can reduce the use of antibiotics without increasing the risk. It can help us to put patients either in the IV or in the PO just by looking at the clinical data as well. That's all I have. Thank you.
Thank you so much, Dr. Temesgen, for that insightful presentation. Sir, please feel free to drop your questions in the chat box.
Oh, there is one question. I think there is one question from Tasavia. In a CLD patient or a liver injured patient, how do we investigate beside the CRP if procalcitonin is not available? So yeah, any clinical problem with, possibility to affect the test interpretation and the state where liver disease is there, the affection can be there and it may be difficult to interpret the value. One thing with, liver disease itself, we may not expect that state of raise, or it can even be normal, or all those kinds of issues. If it's an acute phase of a liver disease with inflammatory process, the CRP may keep on raising. So that's why our clinical decision by adding what we can get from the history, what we can get from our physical examination, the vital signs, all these things are important to incorporate CRP as an additional tool to decide. For example, for the case that I have mentioned, the other clinical data were lacking as far as infection markers are concerned, but the patient was having hemodynamic instability to the extent of septic shock. Even the white cell count was not, raising. The vital sign derangement, we don't see fever and so on. Of course, age matters for that case, but it's the CRP that was significantly, like 600 something. So always our clinical decisions in terms of looking into the patient in detail is the most important thing, I would say. The other question is from Beyene. Can CRP level elevated in immunosuppressed patients in bacterial infection to the same degree to immunocompetent? Okay, yeah, here the CRP level in immunosuppressed cases may not raise to the extent like the immunocompetent ones can have. So that's one of the drawbacks. Not all category of patients can have a raise in CRP. So as we see, even for our routine complete blood count category, you may see like leukopenia and things like that. So normal CRP may not rule out, lack of infection. So we should be careful in that interpretation. That's why looking into the patient as a whole is the most important thing. The other ones, I appreciate. Thank you for the compliments. I appreciate that. And okay, Affordability of CRP to the general population, I think that's a question that Dr. Mehdi, you will address it or someone will address that?
Yes, sure.
Maybe later. So the other, okay, what's the significance of CRP in septic arthritis? It may keep on raising again. This is question from Kibru Kasa. So CRP, even in septic arthritis, can keep on raising. Obviously, it's an inflammatory process. But here, doing fluid analysis, if that septic arthritis is also having fluid there, looking into that will help us. Otherwise, its significance is again for us to initiate antibiotics or not. It's a significant help. If that same patient is febrile, raised CRP, pain, effusion in that same joint, and getting the analysis from the fluid, yes, we can proceed for antibiotics treatment. I understand your concern, but the fact that the septic arthritis is there by itself can cause raise in CRP, be it with the bacterial infection or not. So in that case, it may still be a bit difficult to decide, but as far as the patient's condition and the risk factor identification is there for septic arthritis, we can proceed with the treatment. Okay, the other is from Solan Ayana. How about availability, affordability of CRP? We usually rely on CBC for emergency patients because results are fast and affordable. Especially in resource-limited area, how do you see the efficacy of using CRP for upper or lower respiratory tract infection? Yes, this is, important question for all of us. And even for the European setting, that was what they advocated. Making CRP available at low cost will help to reduce inappropriate antibiotics used in lower respiratory tract infection. It's the same thing I can repeat for our setup, unless there is fast turnaround. When we say point of care test in emergency department, it's something which is a kind of one stop. You can get the result immediately. Just like bringing glucometer and looking into the blood sugar of someone at the triage. So it should be as fast as like that. Unless that's the case, it may be difficult for decision. So availability wise, I think we can get that from the technical details and how available it is from the 1 4 team here later on. Another one from Mohammed. Can CRP levels be used effectively to decide when to stop antibiotics, and how accurate is it in tracking bacterial infection resolution? Okay, yes, as far as the CRP levels come back to normal range, especially if you do have earlier determinations where you use the CRP as an adjunct during the initiation of antibiotics, obviously you can track that, you can repeat the test, and when the CRP levels come back to normal range, you can effectively stop antibiotics. At least this is, the finding from the study so far. So the problem is, we initiate antibiotics for every patient with raised CRP? That's a question because CRP raised can be for lots of reasons. But once you incriminate that for an infectious etiology, patients on antibiotics with a resolution of the CRP from its higher range within that few days time, either you can de-escalate antibiotics, de-escalate meaning maybe you can switch it to low potency like PO antibiotics format or so. You can do that as far as it's within the normal range. Okay, Yomi, why we apply CRP for upper and lower respiratory infections? Why not for others? This is, okay, thank you for that question. This is because at least the studies so far are highly focused. The data is telling us from these respiratory syndromes. That is the reason from my encounter so far. If studies come out, results or data come out from other syndromes, maybe for urinary tract infection or any focus of infection from gastrointestinal tract and so on, obviously we can still advocate for those categories as well. But it's highly focused on the respiratory, both the upper and lower respiratory tract infections, because of the available data on those categories. I think the other is already addressed, the CRP and ESR by Dr. Jane, right?
Yes, it's already been addressed.
The CRP versus ESR. Yeah, that's the same answer I can mention. Dr. Jane answered that. So ESR keeps, raising for a longer duration, and it's marker in chronic inflammatory process as well. So the benefit of the CRP here is they are both non-specific from the outset, but the benefit of CRP is it can raise for acute infections quite rapidly, and it drops to its steady with a steady curve to its normal value within a week with intervention, with antibiotics intervention. So from that point of view, it's quite useful for the acute presentations more than the ESR itself. Okay. There is a question again from Beyene. In a patient with multifocal community acquired pneumonia, who is clinically improving but is still high CRP, shall we continue antibiotics until CRP is in downward pattern beyond normal duration for recommendations? Okay, this is important question again. Just for clarification, as far as the antibiotics treatment is there, the right antibiotics, there is these 5 Ps of antimicrobial instruction, where we focus the right clinical diagnosis, the right drug, the right dose, right duration, and escalation. As far as those things are followed, and the right antibiotics is given for the patient with this multifocal pneumonia, with right duration of treatment, we expect the CRP drop not to take more than a week. So that's what's proven from the studies. So the curves are CRP drops are within 1 week as far as antibiotics coverage is there. So in that scenario, with the clinical improvement, obviously that includes the vital sign improvement as well. That sounds to me like that. And subsequently, a normal CRP, the white cell count can still be at the normal, at the cutoff value for the high range or so. As far as your CRP is normal, yes, either you can stop or you can switch your antibiotics into the like per oral format and so on. Okay, the other question, Surdika Healthcare of the Philippines. Which test is more accurate for general infection, CRP or ESR? From what I see from the studies and the readings and publications so far, CRP is more accurate than the ESR. But the issue is the clinical context matters. Which category of infection are we dealing, and all those kinds of issues, and how is the measurement itself? All this matters. But in general terms, for the emergency utilization, I would say CRP is more accurate. Thank you.
Okay, I think let's take one final question, Doctor.
Sure.
It says it's from Samahe. It says, how frequent shall we follow the CRP level to monitor response and taper our antibiotic?
Okay. This brings us to the curve. If you have seen it, the initial rapid raise, that's the highest raise actually, is within that 24, 48 hours, you see. If you do CRP, let us say, during the time of presentation, and if you repeat it in that 24 or even that 48 hour, you may not see any difference, meaning you may not see a drop at least. So from that point of view, I would suggest to do the first repeat test, maybe like in 72 hours. By then it starts to drop. And subsequently, based on the clinical improvement of the patient, you may make that gap within days. So there is this advocacy nowadays. Most of antibiotics treatments for syndromic approach or whatever, except for some few infections, there are advocacies for 5-day course. Look, in that scenario, you have the first test. Maybe you can get the repeat in the 72 hour, and then maybe you can add a third test to look into the complete resolution or the drop in terms of the curve from the CRP. If we are dealing with pneumonia or urinary tract infection, those kinds of things, I may do it during the time of presentation, then within that 72 hour, and subsequently maybe within that 5th day and so on. But there are no hard and fast rules here. Everything depends on the patient condition. If we are dealing with a patient with a septic shock, let us say, and we put that patient on high potency antibiotics, and we may treat that patient for weeks at times. In that scenario, just mere repeating of CRP may not add anything, knowing that the patient is already, in that critical state with hemodynamic affection, where we are dealing with maybe a bacteria which can cause such a deleterious outcomes and so on. So we may not just do mere repeat of CRP. So there, contextualizing the testing also matters. Thank you.
Okay. Thank you so much, Dr. Temesgen, for the answers. So we can move to our final speaker of the day.
You're welcome. Thank you.
Okay.
Hello, everyone.
Okay. Now we can move to our final speaker of the day. It's a pleasure to introduce Beyene, the marketing manager and product manager at OneFu Philippines. She will provide short overview of OneFu CRP testing, covering its principles, use cases, and clinical value, and showing how this simple yet powerful tool can enhance diagnostic workflows and decision making in daily clinical practice. Please welcome Ms. Beyene.
Hello, everyone. So I'm Ven. I'm the marketing and product manager of One for Philippines. I'm a medical technologist by profession, and I'm also a drug test analyst. So I am thrilled to introduce to you an exciting advancement in inflammation testing, that is the One for Find Care CRP test. So this innovative point-of-care testing is designed to boost lab efficiency, reduce diagnostic delays, and support healthcare professionals in making fast, evidence-based decisions. So interestingly, as what Dr. Jane pointed out a while ago, CRP, or C-reactive protein, was first discovered back in the 1930s in patients with pneumonia. So basically, it has been like guiding clinical decisions for nearly a century. So CRP is a very powerful biomarker used to detect inflammation. So because it rises within just 4 to 6 hours of inflammation onset, CRP is one of the earliest and most reliable indicators available, making it an indispensable tool for clinicians everywhere. That is why OneFull launched this campaign, Antibiotic Overuse, Time to Say No. And the success of this campaign relies on a collective action. So we call on patients to support responsible antibiotic use and recognize the value of CRP testing. For doctors and lab professionals to adopt CRP testing for informed decisions, and for the distributors to help expand access to this crucial technology. CRP testing is used across a wide range of clinical conditions, from pneumonia and sepsis to rheumatoid arthritis and inflammatory bowel disease. So it plays a very crucial role in differentiating between bacterial and viral infections, monitoring chronic inflammatory conditions, and assessing cardiovascular risk. So in cardiology, HSCRP, or high-sensitive CRP, even helps predict the risk of future heart attacks. During acute infections, CRP levels can increase by 10 to 1,000 times, giving healthcare providers a clear signal to guide timely and appropriate treatment. So right now, I will be discussing about OneFull Find Care CRP test. It is designed for simplicity and speed. So it requires just a small finger stick blood sample, as you can see in the slide, only 8.5 microliters, which is less than a teardrop for whole blood and 5 microliters per serum or plasma. You can also see here in the slide that it is finger stick blood testing supported, and it only takes about 3 minutes to get the result. And our whole range, CRP, provides two results already. That is HSCRP and CRP in one. And because it doesn't require a centralized lab, it can be performed virtually anywhere and clinics to mobile units. So one for Find Cure CRP test isn't just quick and convenient, it's also proven. So the one for CRP test has passed the RICWAS International Quality Assurance Program and is backed by comprehensive evaluation reports, which means you get rapid results without compromising accuracy. So fun fact, over 45,000 laboratories worldwide uses RICWAS to benchmark their performance, ensuring top-tier quality standards. So for why do we choose one full CRP? So first and foremost, it's for its rapid results, that's as fast as 3 minutes. For blood collection procedure, it is easier, and it supports finger prick samples that is gentle for children. It uses whole blood sample. There's no need for centrifugation. That will speed up testing by eliminating preparation steps and the need for extra equipment. So it also delivers consistent, clinically dependable data where results closely match those of traditional lab systems, combining lab accuracy with point-of-care convenience. There will be no need for additional reagents or consumables. That will lower operational costs and simplifies logistics, making it practical and economical. That offers high diagnostic value at a very affordable price that is very suitable for budget-limited institutions. So it also requires minimal training for users. It's ideal for use in primary care and facilities with limited technical staff. And because of its compact design, it fits easily in small or remote healthcare settings, improving accessibility. So traditional CRP testing takes hours, sometimes even days. So leading to bottlenecks and delays in care. One first 3-minute testing capability dramatically improves lab workflow and enables timely clinical decisions.
Your slide is now moving.
Oh, okay. So I can proceed. So for as what I've said a while ago, so traditional CRP testing can take hours, so sometimes even days. That's leading to bottlenecks and delays in healthcare. So one first 3-minute testing capability dramatically improves lab workflows and enables timely clinical decisions and enhances the overall patient experience. So in emergency settings, rapid CRP results can help triage critical cases such as sepsis, or respiratory infections, potentially saving thousands of lives. So one for CRP is a child-friendly solution. So needle phobia is real, especially among children. And fortunately, one foot's finger prick method makes CRP testing far less intimidating and much more child-friendly. So with less pain, less blood, and faster results, young patients experience less stress. And for comparison, traditional CRP tests can require up to 10 milliliters of blood. That's nearly 1/5 of a newborn's total blood volume. So when compared to other point-of-care CRP devices, OneFlow truly stands out. So why is that? Because it supports more than 50 test parameters, 67 to be exact, and it is trusted in over 100,000 installations worldwide. And it delivers each test at a cost 10 to 30% lower than many alternatives. It is even used in rural health programs across multiple countries to help decentralize diagnostic services and improve access to care. Okay, so as you can see in my screen, this is the complete test menu for our PIA platform. So this is a total of 67 items in total. So I've just highlighted some items here. That's PCT, CRP, CRP, PCT, and of course our interleukin 6. So I've highlighted these test items because it was mentioned a while ago by our doctors that procalcitonin, CRP, and interleukin 6, the inflammatory markers commonly used in sepsis, diagnosis, and management. I would just like to stress out that all of these are also available in our Fine Care platform. So just to summarize, this is subdivided into six. So we have diabetes and kidney function markers. We have sex hormones and thyroid function. We have cardiac markers. We have tumor markers. We have infectious and inflammation markers. And of course, our parameters for the respiratory infection. So unlike older latex-based CRP tests, which are often hard to read and prone to operator error, OneFu uses advanced fluorescence immunoassay technology. So this ensures quantitative, highly accurate, and easy to interpret results. Fluorescence detection removes the subjectivity seen with latex reactions, and this allows consistent outcomes regardless of who's performing the device or the test. So for my next slide, semi-automated CRP testing systems often require complex machinery, calibration, and technical training. So in contrast, OneFu eliminates these barriers. So there's no need for special equipment or extensive training, just a simple procedure that delivers precise results in minutes. So it's ideal for remote clinics, mobile health units, and field hospitals where time and resources are very limited. So while high throughput analyzers excel at handling volume, they often fall short in terms of speed for urgent cases. That's where OneFu comes in. It complements these systems by quickly processing pediatric or time-sensitive samples, enabling a hybrid workflow that significantly boosts responsiveness. So in fact, using POCT to triage urgent samples can improve turnaround times by more than 50%. OneFu CRP testing solution brings together the best of technology, usability, and affordability. So whether you're in a large hospital, a rural clinic, or a disaster response zone, this compact yet powerful tool meets your diagnostic needs. So it also aligns with the WHO's assured criteria, that is affordability, sensitivity, specificity, user-friendly, should be rapid, equipment-free, and deliverable to our end users. So what's the value proposition that OneFu POC CRP brings? So for patients, a simple and affordable fingertips test can help avoid unnecessary antibiotic use, reducing the risk of secondary harm. So it prevents the spread of superbugs, ensuring effective treatment options remain available for critically ill patients. For clinical departments, it increases the detection rates for bacterial infections. It solves the incorrect empirical antibiotic prescription. It's faster and smoother diagnosis for emergency and pediatric patients. For the lab, the POC fluorescence immunoassay CRP platform offers superior immune methodology for enhanced performance. It's simplified operation and sampling for ease of use, faster results in decentralized application, improving decision-making time, and it also improved cost effectiveness. So this is a win-win for everyone involved. Clinicians benefit from quick, evidence-based diagnostics. Labs see reduced workflow and faster throughput, and patients enjoy quicker and more comfortable care. But perhaps most importantly, CRP-guided testing plays a major role in combating antimicrobial resistance. So it helps reduce unnecessary antibiotic prescriptions by as much as 64% in certain studies. So to end, OneFu CRP solution is more than just a diagnostic tool. It's a step towards smarter, more accessible, and more compassionate healthcare. So let's take this innovation forward together. So thank you very much, listening, and I'm very, very sorry for the little inconvenience.
Thank you, Vane. Sorry for the technical problem. We're very sorry. So we can take one or two questions from the audience. If you have any questions on wonderful CRP. Okay, so thank you again, Vane.
Thank you.
Okay. So as we move forward, we would like to take a brief moment to hear from our valued partners at Blue Health Ethiopia. Please join me in welcoming Dr. Hino, a representative from the organization, who will share a few words with us.
All right. Thank you very much, Dr. Mati, as well as all the participants or the panelists today, Dr. Temesgen, Dr. Jane, and also Ben. So, to say a little about Blue Health Ethiopia. Blue Health Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer. And we are, So Blade's virtual seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And Blue Health Ethiopia is an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. So Blue Health Ethiopia is a healthcare innovation company dedicated to enhancing emergency response, professional healthcare education, and community health outcomes in Ethiopia through our flagship solutions such as the Darash mobile app and an advanced continuous professional development platform. We address critical gaps in emergency care, healthcare training, and knowledge dissemination. Blue Health CPD is a web-based learning management system designed for Ethiopian healthcare professionals to offer flexible, accredited courses that fit busy schedules, allowing users to learn anytime, anywhere, via their computer or smartphones. With self-paced modules, virtual seminars, and interactive assessments, professionals can earn continuous educational units that will help them for their license renewal while staying updated on medical advancements by our experts. So thank you to all the panelists as well as Dr. Mati and all the participants that attended today's the 120th Blue Health virtual seminar.